Since the sorafenib and lenvatinib questions are done and dusted, that sorafenib and lenvatinib is non-inferior, based on the sharp trial which came and the reflect trial. So I will not be discussing those part, but the latest combination which is at present recommended, that is combination of atezo plus bev, which I will be discussing as first line in unresectable HCCs. So Anand sir already covered the TKIs and a lot of plethora of TKIs available to us in near future. Should I put it in the full
Yes,
screen?
sir.
Or
Yes, sir. So you have to go full screen, sir.
Oh, okay. So starting with the global incidence, Dharmesh sir already covered.
That's still not on the full screen mode, sir.
It is on full screen on my side actually.
Sir, you have to reshare and you have to select share the entire screen option. Yes, sir. Green button, dialog box open. The first option, select the entire screen and then share.
Okay.
Yes,
I
sir.
hope it's okay. So the global incidence and mortality has been covered by Dharmesh sir. Liver cancer does present a significant burden in terms of incidence, but more than incidence, I think the mortality is something which is significant compared to other cancers like lung and breast, where there are a lot of treatment options. While in liver, there are not much of treatment options, and any treatment options is welcomed with enthusiasm. So as mortality is considered, it is the third leading cause of global cancer mortality, accounting for 8.3% of cancer death. Now, global incidence, the global incidence is around 8 lakhs per new cases, and 75 of them are in lesser developed region of the world like us. And liver cancer is fifth and ninth most common cancer in male and female. Men have threefold higher risk of developing liver cancer than women. Now, coming to the HCC, HCC is being the most common type of liver cancers. There are other cancers like cholangiocarcinoma, sometimes mixed adenocholangios, angiosarcomas, and hepatoblastoma. So that is not the point of discussion today. These are rare tumors. We will be focusing on the HCC, the classical HCC. So risk factors are the HCC. There are many ways it get damaged, like with viruses, alcohol, NASH, and rarely aflatoxin mushrooms. Whatever the reason the chronic damage happens, it ultimately can lead to a cirrhosis and ultimately into HCCs by acquiring multiple mutations. Now, in Indian scenario, what we have as data is 35 new liver cancers in 2020, ranking the 10th among the all cancers. So not the most common type, but yes, it is the 8th most common cancer, causing the death in nearly 34,000 patients in 2020. And 5-year prevalence rate is 2.8 per lakh, which shows the unmet need it poses to us. So these unmet needs include majority of patients are presented in advanced stage. So I am working in a GI setup, AIG hospital. We see lot of, or I should say the maximum number of HCC all over the India, but majority of our patients are still in the advanced stage. So rarely we find a upfront resectable or HCC which can be downstaged and go to transplant. So HCC 5-year survival is 2.3, which is a grim picture, and current options opted for majority of population is TKIs because of the cost issues, and the lack of better treatment is something which is unmet need too. Now, this slide is already shown by P.N. Rao sir also. 2007, we had sorafenib sharp trial. We showed survival benefit of around a month or so. And till almost a decade, we had nothing to offer except sorafenib. And then came the options of lenvatinib, which came out to be a non-inferior, not exactly a superior option. And then now here Atezolizumab, Bevacizumab has come as a first-line treatment option to offer actual superiority than sorafenib and exploratory probably over to lenvatinib also. So what is the rationale behind this combination is HCC has multiple ways it escapes the immunity. For example, there is trafficking of T cells. So spontaneous regression in HCC is known, which suggests that there is an immune system mediated anti-tumor activity. In tumor infiltrating T cells are seen up to 50% of HCC, which shows that these T cells whose function is to kill the tumor cells are not acting. Somewhere they are getting energy. So this is also shown that the tumor which have higher T cells infiltration actually has a better PFS than non-immune hot tumors. So these HCC may evade this immunity cycle by expressing molecules like PD-L1, CTLA4, TIM3, and LAG3. Now, against these molecules, what we have is these molecules like Atezolizumab, and the rationale behind the Bevacizumab addition to this combination is that it enhances the VEGF mediated immunosuppression to promote anti-cancer T cells. So while the Bevacizumab normalizes the tumor vasculature, increasing the T cell infiltration, Atezolizumab restores the anti-cancer immunity. Also, Bevacizumab decreases the activity of immune suppressive cells like T regulatory Treg cells and MDSCs, stromal cells. Now coming to this study, IM-Brave 150, which was a phase 3 trial where it compared Atezolizumab versus sorafenib. So this is a direct comparison with the standard of care, sorafenib, and it was randomized to 2:1 open label. So they were stratified based on the region, Asia, excluding the Japan. ECOG performance should be preserved, and baseline AFP less than 400, more than 400. They included locally advanced or metastatic or unresectable HCCs in which the local ablative therapies could not be given. And the treatment, either Atezolizumab or sorafenib, was continued till there is unacceptable toxicity or loss of benefit, and survival follow-up data was evaluated. The high-risk patient included this subgroup, that is, patient with have main portal vein, the bile duct involvement, more than 50% liver occupying tumor, and they were evaluated with RECIST 1.1. There were few secondary endpoints like overall response rate also. Now the baseline, this is 2:1. So Atezolizumab had 336, while sorafenib had 165. This is well balanced study if you include the 2:1 distribution, whether it is a region wise, performance score, childbirth score, BCLC. What is this significant is in Atezolizumab arm, they also included BCLC C. Then they had substratified with viral infections, alpha fetoprotein, and disease burden. What they found as a primary endpoint was in Atezolizumab, the median PFS was 6.8 months, while sorafenib had just 4.3 months. So though numerically, clinically, it is just 2 months difference, but statistically, it becomes a significant HR gain of 0.59 towards Atezolizumab. Now, follow-up systemic therapy post this is recently updated analysis suggests that in sorafenib, immunotherapy or even chemotherapy were offered, while in Atezolizumab, the tyrosine kinase was offered in the majority post-progression. Now coming to the overall survival. So we found that the PFS benefit is there of around 2 months. Overall survival benefit, we actually found that there is a significant HR gain, 0.58 in Atezolizumab, while it was sorafenib in 13 months only. So overall survival is not achieved in case of Atezolizumab, while sorafenib we achieved at the end of 6 months. So updated overall survival, which was recently released in August 31, 2020, what they found is median overall survival in Atezolizumab is 19.2, while sorafenib is 13.4. This is a significant benefit with compared to standard of care treatment, that is sorafenib. So this gives Atezolizumab as a category 1 recommendation as a first line unresectable or metastatic HCCs. This diagram shows in any of the subgroup we take, whether it is performance score, BCLC, viral infection, alpha fetoprotein, the Atezolizumab is favored over sorafenib. So except the BCLC stage 2, where sorafenib is slightly benefited, whichever subgroup we take, Atezolizumab scores better numerically as well as this forest plot analysis. So what are the response rate? Sorafenib response rate, confirmed overall response rate was just 12, while in Atezolizumab it is nearly doubling of the response rate. Out of this, what is specific is there were group of people who actually achieved a complete remission also in Atezolizumab group, while 0 patient on sorafenib achieved complete response. As we discussed, majority response was this stable disease in sorafenib, that is TKI subgroup, and the median duration of response is 6.3 in sorafenib, while not achieved in Atezolizumab. So updated response as of cutoff of August 31, 2020, and duration of response. Median duration of response was 18 months in Atezolizumab, while just 14.9 months in sorafenib. Again, there were subgroup which achieved a CR. This gave more confidence to offer Atezolizumab upfront rather than sorafenib. So as far as safety summary, many clinicians have this notion that Atezolizumab can sometimes decompensate the residual function. However, this side effect is not reported in clinical trial. So any grade side effect does happen in 98 patients. However, clinically significant grade 3, grade 4 adverse effect happened only in 57 out of 329. That is less than 20% of the patient. The grade 5 adverse effect, that is life-threatening side effects, happened only minority of the patient, of only 2 out of 329. So you can see that treatment associated decompensation, I do not think many clinicians which find it risky to give Atezolizumab in borderline high bilirubin because of the disease should worry about grade 5 adverse effects. So adverse effect leading to withdrawal for any component either from disease or treatment related is 16. Dose interruption required in 50 patients, and modification of sorafenib was required in 37. So IMbrave 150 illustrated some typical differences safety profile between the tyrosine kinase inhibitor and cancer immunotherapy-based regimen. So what it suggested is, while sorafenib had a significant grade 3, grade 4 adverse effect, Atezolizumab did not have as high as grade 3, grade 4. They did have side effects, like many patients developed the diarrhea as colitis as Atezolizumab combination. Some had Bevacizumab induced hypertension, but not exactly grade 3, 4 compared to TKI. Now, the rate and grades of bleeding between the IMbrave 150 were similar between the treatment arm. So many people are even now afraid to offer Bevacizumab as treatment option, considering the possibility of gastric varices in patients. Though in this trial they have not included with impending bleeding of varices. So what they found is, whether you consider sorafenib, lenvatinib, or Atezolizumab, the all grade bleeding is kind of similar. It is just 4 in lenvatinib, sorafenib it is 4. In IMbrave study, it was Atezolizumab had 6. So IMbrave 150, sorafenib, Atezolizumab both had grade 3, 4 equal. In Reflect also, lenvatinib versus sorafenib had equal. All of them have VEGF inhibitions to certain extent. So bevacizumab causing variceal bleeding is not something to afraid of. Though if there is an impending varices, then we should get it bending or sclerotherapy done. Impending varices should not be included, should not be given bevacizumab without getting addressing them. So bleeding events with systemic therapy were typically low in grade and unrelated to varices. Personally speaking, last 2 years I have been in AIG. I had just one patient who developed variceal bleed post atezolizumab. Probably in that case, they happened to not present to the hospital when the bleed happened. So varices activity was assessed beforehand, offering any of these atezolizumab or sorafenib combination. In atezolizumab, they have these type of epistaxis, esophageal varices, minority 2.4, GI also similar. So hepatitis occurred at similar rates between treatment arms in IM Brave 150 and atezolizumab and sorafenib. So hepatitis in atezolizumab, any grade 43, grade 3 4 clinically significant was 21. Similar number was present in any grade of sorafenib, or grade 3, grade 4, 17. So assessment, they also had patient-related outcomes like quality of life, physical activities, and other symptoms like fatigue, pain, appetite loss, which do happen with tyrosine kinase inhibitors. What they found is atezolizumab, the median time to deterioration was longer. So patient overall quality of life was much preserved in atezolizumab versus sorafenib. I had one patient recently evaluated on atezolizumab. So he had received 21 cycles of atezolizumab with absolute preservation of quality of life. He absolutely no hand-foot syndrome, no fatigue, nothing. He tolerated atezolizumab very good for 21 cycles. So that is what I want to emphasize on this slide. So quality of life must be considered when choosing a regimen. We cannot cure the patient, but let's not deteriorate the quality of life. Whatever time we are giving, we should give it a better quality. They should be able to enjoy it. So compare atezolizumab or sorafenib. I just covered. Atezolizumab had 13 months time to deterioration, while sorafenib had just 5 months. And whichever side effect we consider, appetite loss, loose motions. So loose motion definitely way less in atezolizumab compared to sorafenib, being a TKI. Fatigue, treatment-induced fatigue is less in atezolizumab. Jaundice, decompensation, less in atezolizumab. So here comes the systemic therapy options for HCC. Very simple. We do have sorafenib, lenvatinib as treatment options. However, personally speaking, patient is fit for treatment, no variceal bleeding, finances are not limited. Probably atezolizumab is what we will offer as first line. As a second line, Dr. Anand Kulkarni already covered, Neo has been chucked off as a treatment option because it did not meet overall survival benefit. Though it was given an accelerated approval on a phase 2 trial, but after the updated overall survival, no benefit, it has been removed. We can offer regorafenib, cabozantinib, ramucirumab as treatment options. There are group who has been offering based on the phase 1 studies Neo EP combination, but probably at present widespread acceptance of this combination are still awaited. So this is the guideline which we have discussed. So HCC, if it is in child pug A, B, resection, treat, transplant, if they are fitting in the transplant category, we can offer these subgroup who are not transplant eligible or inoperable upfront, loco-regional therapy as TACE, TARE, SBRT sometimes if there are portal vein invasion. Though it is institutionalized practice, and systemic therapies as atezolizumab, len, or sora. Clinical trial, downstage if achieved and patient become transplant eligible, then probably transplant later point of time. Incidentally, I'll just quote recently a patient got operated a week or 10 days back. The tumor was at present inoperable. A portal vein grossly infiltrated was there, and the tumor size was 14 centimeter. We started atezolizumab as kind of a treatment option. the absolute wonderful response after 3 months, 3 months, 6 cycles, and the tumor reduced to 10 centimeter with portal vein got free, and recently patient got operated resection done. So probably in future we will have more data of Atezolizumab and other combinations offering in this subgroup of patients who are upfront inoperable but get good response and later got operated. So metastatic disease, Atezolizumab and similar treatment options, SORA and LEN remains treatment options. Second line treatment do have multiple treatment options like Nivo-EP combination. Pembro has been used. So this is for future. I have included two more slides from my side. What are the key ongoing randomized trial? So we can understand if Atezolizumab has come all the way to the first line, more combinations are bound to come. So these combinations are under study, like Len Pembro versus Len, which is again phase 3 studies. So TKI plus TKI plus immuno-oncological drug, Himalaya IO combination versus standard of drug, TKI cabozantinib plus Atezo versus sorafenib, IO Nivo-EP versus SORA or LEN. So all these trials are based on certain phase 1, phase 2 studies like Keynote 524 or Study 22 or Celestial studies, and probably future will tell what more options we can offer to the patient at these type of patients. Now, selected, though my topic is metastatic inoperable, just to mention in adjuvant or neoadjuvant immunotherapy, again, there are a lot of trial, and we were fortunate enough at AIG, we could host this Emerald 2 trial, and recently we could enroll one patient on this trial also. So this Atezolizumab combination, which I shared a patient there where we got a good response. This is also under study where they have actually offered Atezolizumab in that subgroup of the patient versus active surveillance. So with this, I will conclude my last slide. So combination of Atezolizumab has demonstrated efficacy in unresectable HCC in the phase 3 trial named IM Brave 150. It was statistically significant, clinically meaningful in terms of overall survival, PFS benefit over sorafenib. This also reduces the deterioration of patient-related outcome, physical functioning, role functioning, and key symptoms like fatigue and hand-foot syndromes, diarrhea. Positive phase 3 data for Atezolizumab highlights the benefit of targeting multiple steps in cancer immunity cycle and has the potential to transfer the current treatment paradigm for first-line unresectable SCCs. We will see more combinations in future. At present, treating SCC is less confusing. When we will have more treatment options, then probably it will get more confusing which one to choose and offer first. With that, I will end my slides. Thank you very much.